go. Okay, so welcome to our March learning session. Just a friendly reminder, please mute your phone or computer when you're not speaking. I want to begin first with our acknowledgements. It's been updated a little bit. Our webinar is supported by HRSA of the U.S. Department of Health and Human Services as part of the Emergency Medical Services for Children Innovation and Improvement Centers Award, totaling $1.5 million with 0% finance with non-governmental sources. The contents are those of the authors and do not necessarily represent the official views of nor any endorsement by HRSA, HHS, or the U.S. government. For more information, please visit HRSA.org. None of the speakers or planners for this session have any conflicts of interest. That includes Kate Remick, Diana Finja, myself, and Crystal Bart. Report has been received for this activity. Should you detect any bias in this presentation, please note such on the evaluation or reach out to Diana Finja, our nurse planner for continuing education. To obtain nursing CEs, you can either do this QR code or a link will be provided in the chat box. This link right here at the end of the learning session. Our continuing nursing education is approved by the Emergency Nurses Association for 1.5 contact hours. You must sign into the webinar with your name, email address, and name of your facility. You'll take the short evaluation, and after you take the evaluation through REDCap, you should receive a completion within 48 hours of certificate. And if not, please contact myself or Diana. So our brief agenda for the day, we have 4 team presentations that will be followed by some discussion on the final remaining tasks that we are asking for all of our participants, and that will include the final team presentations in April, completion of the NPRP assessment and exit survey, and we'll give you details about our certificate of appreciation. We'll also touch briefly on sustainability efforts and some community practices and opportunities. You all are welcome to join, and then I'll close up with a few housekeeping items. So with that, we can begin with our team presentations, unless there's any questions right now. Okay, well, we can go ahead and let Toma Children's take over. I don't know who's speaking for you all right away.
Hi, I'm Kate, one of the nurse practitioners at Comer.
Great, Katie, you can take it away.
Okay. So our project consisted of a multidisciplinary team. We had physicians, nurses, and nurse practitioners that participated. Just to kind of summarize our emergency department. So we have a freestanding emergency department in the academic institution. We see about 40,000 patients per year. We have 24/7 provider coverage. And we focused our project and quality improvement in our fast track area. And in that area, we have ESI levels 3, 4, and 5. We see about 10,000 patients in the fast track per year, and that's covered by nurse practitioners primarily. We cover 12-hour shifts, 6 days a week. So we only cover 11 a.m. to 11 p.m. Next slide. So our focus for the PRQC was abnormal vital signs. Like I said, we did it in our fast track area. The gap that we had noticed was that, we have a quick turnaround in our fast track area. We noticed that there were vital signs that weren't necessarily being reviewed by the provider or repeated as necessary or per the ED's assessment and vital sign policy. So we aim to improve that communication process and the reviewing process of abnormal vital signs by our nurse practitioners. So the process consisted of creating a best practice advisory. It triggers if the last vital signs are abnormal, and then it fires in our discharge navigator. So it pops up at the time of discharge when we're going to discharge. That way we can evaluate prior to selecting the final disposition. And next slide. So the way we set up our slides, we set them up a little bit more so that everybody was able to see kind of our model for creating the best practice advisory, where our cutoffs came in, We use some pre-established parameters that is within our EMR. So we didn't want to change what was already established in Epic and our flow sheets from a nursing standpoint. So we utilize those age contacts and cutoffs. And so this slide shows where our systolic blood pressures were and what was considered newborn, infant, toddler, preschool, school age, and young adult. And then in the center in the red is what shows our warning minimum and maximum ranges. So this is how we created the best practice advisory and what we used to trigger the advisory. And so next slide will show diastolic cutoffs. And then the following slide will show our heart rates, temperature, respiratory rate. And I think the pulse is in there twice on accident. That was a duplicate slide. But this showed where our, what we utilized. And then the following slide actually shows the best practice advisory. So I think this is probably the coolest part of what we developed. So this is what pops up in our disposition navigator. And this is a test or just a trial, but this model shows, for example, if the temperature was abnormal, it's flagging it based on the abnormality, and then our minimum maximum ranges are at the bottom. So it's showing what we expect to be normal based on what's already established within our institution, and then what was abnormal. The best practice advisory then allows the provider to reorder the vitals and reevaluate, state that they can discharge that we've reviewed the vital signs, or put an other comment in, and that was for tracking and reviewing purposes. It also has the ability to just order the vital signs right from this best practice advisory. And so with our project, we ended up doing entering baseline data in 2 PDSA cycles. We entered a total of 91 charts, which is about 30 charts per PDSA cycle. Our first cycle.
Just a second, Katie. If anyone's on the call and has not muted your line, can you please mute your line? Thank you. Sorry, Katie, go ahead.
That's okay. So our baseline data was from February 14th of 2019 to March 11th. And that was just a little bit of, backtracking and preemptive data prior to implementation of the best practice advisory. Our best practice advisory went live on April 14th. Of 2019. So we utilized there about 30 patients worth of data that had fired the BPA. We had a lot more that actually fired, but for sake of inputting data, we utilized 30 charts equally. And then we also did a second PDSA cycle from May 29th through July 4th. And that involved getting feedback from the nursing staff as to what they liked about the best practice advisory, how can we change it? Is there anything that would make it better or worse, or help with their workflow, since the nursing staff is who is actually repeating the vital signs? We had a lot of great feedback with the vital sign best practice advisory. As you can tell from this graph, or maybe not, it's a little bit hard to read on the slide. But once we had the abnormal vital sign process in place, we had 100% notification, which was the goal. It was to improve that notification process. There wasn't a great way to track our notification process prior to implementation. We had no written sort of standard to say, was the provider notified, or was it just that the nurse knew that these vital signs were abnormal and they used their judgment to repeat them. So there wasn't a great tracking system before, but it definitely increased our compliance, and we had 100% rate of notification. We also had something that we noticed is our pain is this is something that we continuously work on and continue to improve in our institution. But pain was not reassessed on all of these patients. But from a general quality improvement standpoint within our institution, we do have a pretty high pain reassessment. It just happened to be not captured in our data here. Next slide. And so this is that same information showing the improvement, or the patients with abnormal vital signs being captured in our notification process. So that started with our PDSA 2 and 3 cycles. And then the same data regarding patients with standard vital signs and pain assessed. Next slide. And then this slide is more information on how the best practice advisory was built. So we thought that this was nice to include for other institutions in the event that other EPIC related institutions wanted to build something like this and utilize this in their EMR. We included how the BPA was built. So that's the following two slides. And that's it. We did see improvement in clinically relevant abnormal vital signs, so specifically heart rate, respirations, and temperature. We had improvement overall in the times that those were repeated and then had normalized prior to discharge. And that's it.
Thanks, Katie. Lots of great work. Oh, go ahead, Kate.
Sorry. Yeah, I was just going to say thank you as well, and it is great work. Betty actually put a question in the chat box, and she was just asking if the BPA was only specific to nursing.
So the way we developed it, because of the how large and how many staff and residents come into play, we piloted it in our fast track. So it was designed initially and set to trigger only for nurse practitioners, which there's only 2 of us at the moment. But eventually the goal is actually to roll it out to all providers. The nurses actually can't see the best practice advisory. They just get the order for the repeat vital signs. Right now it's set to trigger from a provider standpoint to notify the provider of abnormalities. But we're working on changing that so that there's a view-only access for nursing and then an actionable advisory for the providers. And the goal will be to roll that out to all providers, residents, attending physicians, moonlighters, and nurse practitioners.
Great, thank you. And then could you also just speak briefly about how you've gone through trying to get the EPIC piece built and who you've worked with and kind of your internal process around that?
Sure. So I work closely with our EPIC team, our IT team. It was a lengthy process. So it took us about, I want to say 6 months to finally get it in place. I want to say maybe even a little bit longer than that. We started in August of 2018 trying to get like the foundation for the BPA kind of designed. And then it took a lot of kind of manipulation with the BPA in order to get it to exactly what we wanted it and to try and set it so that it only fired for certain providers. Because like I said, with it being so large and so many factors, we wanted to limit our data to see if it worked prior to expanding it out to the entire ED. So that took some navigation, but we worked with our EPIC team in order to do that.
I think this is really helpful just to hear a little bit about the process, because I suspect there are a number of other folks on the call whose systems use EPIC, and these can be lessons learned of how to translate that into other systems. So for those of you that are on the call and use EPIC, it might be worth reaching out to Katie and her team to better see how you can maybe make connections to integrate these kinds of builds. The other thing I would add is that while electronic medical record optimization we know takes sometimes the longest amount of time to implement, as you mentioned, that it took over 6 months, but it can be oftentimes the most impactful because it's readily integrated into your day-to-day processes. So thanks for sharing that.
Thank you.
Is there anything else anyone else wants to ask of Katie or her team?
Kate, Katie, this is Diana Fendia. Quick question. I was looking at your slides where you had the minimum and the maximum alerts for your staff. Are those charts posted in your EDs, or do they have badge buddies? Or how did you get that information out, and how do you make it readily available to them? Because again, I think those are great tools that potentially can be borrowed by other teams.
Yeah, so this it came from our EPIC team. It took a lot of many emails to try and actually find this information to see what our context was in terms of age and cutoffs. So it is not actually, I don't believe it's posted anywhere within our emergency department, but it is what's utilized for our nursing flow sheets. So it's what triggers our abnormalities within the flow sheet when nurses document. And we utilize those same parameters for the best practice advisory. I do think it is a good idea to post it, and that's something that I also intend to do, as we try and roll this forward and do more education on it. But it's not currently readily available.
Well, thank you very much. You did a wonderful job there. Thank you.
Thank you.
Yeah, I had a question. This is Pat Frost. Are you planning on holding this work out to the EPIC annual meetings or something for broader dissemination? I think something like this would be very important to share.
So I have not talked yet or thought really into the EPIC meetings. We're presenting this information at our local ENA conference. But so far that's the extent of, dissemination from that standpoint. We plan to try and present it institutionally at our quality symposium, and then plan to publish some of our data from a best practice advisory standpoint.
I would really encourage you to work with your IT department, because typically people from IT in a facility like yours would be going to some of those meetings. They have user groups and stuff, and this is where the new ideas and innovations for incorporations and next generation platforms are incorporated.
Okay, that's helpful to know. Thank you.
Any other questions?
Great.
All right. I guess we can turn it over now to Olivia with MOKAN Rocks and give us a quick update on what y'all have been up to.
Hey, this is Olivia. I've also got Laura here with me, another site facilitator. So I'm just going to give a brief overview from kind of our teams in general today. Go on to the next slide. So originally we had 10 sites that started out in the collaborative. So just to give you kind of a recap now that we're pretty far in, one of our sites had to drop off pretty early for various reasons. And then one other of our sites recently had to kind of drop off also for various reasons. But we found that we made some really meaningful connections in both of those sites. So we're really glad that they were able to at least start off the collaborative with us. It really brought up their awareness for pediatric readiness in their EDs and made some meaningful connections. And so we're glad that they started with us. And I think that they'll both participate in future collaboratives. So, all right, next slide. This is a slide that I actually showed in our very first site presentation that we were asked to do with some of the characteristics of our hospitals, but I can give a quick update. So just in general, most of our facilities are rural. They have very low amounts of pediatric patients they've seen a day, and their average PR score was about 60. Our biggest common gaps, just like most of the other teams, were our vitals, and so most teams chose to do that bundle. We only had one team that was prepared to actually work on the disaster bundle, but since we started, we've seen several other teams dive into disaster, which I think has been really encouraging, because I think had you asked them a couple years ago to look at their pediatric disaster, they would have thought, oh my gosh, we have so many other things to worry about before we do that. So they've made such great progress that they're actually looking into other areas to work on, and I think that's great. So that's been really exciting to watch. All right, next slide. So like a lot of other sites, our main issues that we've tried to resolve have been helped by using badge buddies, just having policies updated and everyone on the same page about, what vitals to look for, having the physicians on board with those quality collaboratives or quality initiatives, and moving forward there, having locking scales for our kiddos and weighing them in kilograms, and then also having hard stops in the EMR for vitals. Those have been some of the major things that have helped us moving forward. We've talked about doing a collaboration for our disaster preparedness teams. I think one thing that they've struggled with is, one of our teams has been doing disaster from the beginning, and it's hard for them on our conference calls to get a lot of collaboration done in their specific bundle with other teams. So it's been nice to kind of reach out to other teams outside of our state to talk about what their disaster preparedness looks like and kind of collaborate with them. So we're working on getting a meeting set up between some other states also that I think will be really helpful. One of the challenges that I've brought up in the past that we've had is communication, not only with our other teams' communication in departments and their hospitals, but also with us as facilitators, where our team is, I think, a little unique in that our facilitators, like myself and Laura, we work in the transport department. So we work closely with our ED, but our main facilitators aren't full-time employed through the ED. So we've had some struggles there too, just like you would imagine anyone else would, trying to set up meetings and with different departments in your hospital and getting things done and move forward and all being on the same page. So recently we've added Laura to our team, who's our transport EMS outreach coordinator. So I think that that's really going to help us not only in coordinating with outside facilities, but also just in our own facility and making sure we're on the same page. So that's been really helpful for us. So I think that's all I have for you. What kind of questions do you have?
Great, thank you. Any questions? MOKAN Rocks?
This is Kat. I was wondering, even though they have a very small number of patients that they see, did you have, do you know what percentage of their total ED volume children represented?
I don't have it in front of me. I think it was about 5%.
Okay, thanks.
On average. I mean, there's like one or two of our hospitals that see pediatric patients quite frequently, and then, you know, one or two that see them once a month, and then several in between. So.
Just to follow up on that, one of the discussions that was had on our last learning session call was the aggregate number of patients that are being seen at your affiliate sites versus the number being seen at the training site, and that oftentimes those can be fairly equivalent, so that the impact of all the affiliates combined in terms of number of children seen can be relatively similar to the total number being seen at that training site. And it might be something worth thinking about or looking into because it helps to create a little bit more of a case for ongoing pediatric readiness efforts across those sites. Great work that you all are doing. Any other questions for Laura and or Olivia before we move on? Great. Thank you guys so much for sharing. Next up, I think, is the Oregon Pediatric Readiness Program. Rachel, is there someone from your team who's, oh, Jessie. Jessie, are you speaking next?
Hi, this is Jessie.
Hi, Jessie, go ahead.
So I'm from Tuality Community Hospital in Hillsboro, Oregon, and we could go to the next slide.
Okay, just a second. I'm sorry.
I'm back. Sorry.
Oh, good. Perfect. I just lost audio for just a second.
Kicked me off for some reason, but okay, I'm back. I'm sorry.
Okay.
So next up we have Oregon. I didn't hear if Rachel or Jessie should be on the phone. Next slide. Okay, thank you. I'm here. Thanks. Go ahead.
So we had difficulty with having a pediatric readiness care coordinator. We started out with it being management, and they weren't super enthusiastic about it. And so I've been working on this project for about 4 months now. So this is kind of where we're at with me working on it for about 4 months. We have set some goals. We got our initial statistics in and set some goals. And our goal, we've initiated some badge buddies to meet these goals. our two goals are that all the children are weighed in kilograms, and that we have a full set of vitals, including mental status and pain in our full set of vital signs. We can go to the next slide. So we really love the pediatric readiness for emergency departments from the American Academy. That worked really well for us, just to use it as a playbook to refer back to. We also have found great benefit in the monthly phone meetings with all of the people from Oregon. And we have been able to implement with the monthly education. Like last month, we had education on abuse and neglect in pediatric patients, and they brought up that all pediatric patients should be put in a gown for abuse and neglect surveillance by the physician. And that was a big change for us, because for nursing, because we didn't, if a pediatric patient came in with just an earache, we might not necessarily place them into a gown, but our physicians and nurse practitioners and PAs have really appreciated that. Some of our challenges have been, we've had a difficult time with the data entry and interpretation, possibly because I'm just kind of new at it, and I just haven't quite figured that out. And then the turnover, we've had like 4 different people representing as the pediatric care coordinator, and so the turnover really set us back. We could go to the next slide. So in using the pediatric readiness kind of as a guidebook, we first started out, practice change just went through the list of like all of the equipment, and that was the easiest thing for us to do, just to make sure that we had all of the equipment that we needed. We found that we were really lacking in intubation equipment for our kids. We had all uncuffed tubes, ET tubes, and so our physicians really wanted us to have cuffed and uncuffed, and so we were able to develop a pediatric airway roll that went through PALS from start to finish on all of the tubes, and we're going to have a simulation next week just to kind of test that pediatric airway roll. And that's about it as what we've been up to.
Thanks, Jessie. This is Kate Remick. I'm just wondering if you can comment a little bit more on a couple pieces. The first, you just mentioned that you had difficulty with the data entry and interpretation, and I'm wondering if you could just describe some of your challenges a little bit better, because this will help us as we proceed in kind of future efforts, and what part has been most challenging for you.
I think Sierra might be on the line, and she has done the data entry, so maybe she can comment on that. Okay.
Hi, sorry, can you hear me?
Yeah.
Oh, can you repeat the question? Sorry.
Sorry, Sierra, this is Kate Remick. I was just asking about what pieces of the data entry and interpretation have been most challenging for you guys? And that's so we can begin to think about what improvements we might need to put in place.
Sorry, I'm just trying to.
Yeah, we met with Rachel and some of our team. Part of it has been just as Jessie commented on, sort of the turnover of our team and getting people in place to actually get this off of the ground. And then once we were able to get some of our baseline data and get it into the system, just seeing the way that some of that is displayed within the system just didn't quite make sense to me, and it just didn't seem like it was spitting out, and I didn't track it, and I should have at the time. I didn't track it on like another Excel sheet or something about how I answered all the questions for all of the charts, but from my memory, what I entered versus what it was showing me didn't seem to align, and so as we start to get data for our first couple of PDSA cycles, I think we're going to sort of track that in 2 ways so that we can make sure that the information that it's showing us in the system is actually what we we're seeing in the charts. But without having that comparison, I don't really have a good reading on it at this point.
Okay, so it wasn't an issue of data entry as much as it was you're worried that the results were not what you had actually entered into the system.
Correct.
Yeah, okay. Okay, that's helpful. I guess my other question was more for Jesse, which was just related to the turnover. You mentioned that there are 4 different people that had served in this tech role. Are you able to speak to kind of how you all transitioned between the role and just really fast, there's a lot of background noise, so if someone is on the phone and not on mute, if you could please mute your line. But you mentioned there were 4 different people in this role, so if you could just talk about kind of how you transitioned and how you were supported through your ED leadership and or hospital leadership as you transitioned.
Yeah, we had a manager, the first manager that took the role on, assign a couple of nurses to do it with her, and they, at what I gather is that they were just kind of confused as to what the process was, and then that manager abruptly had to leave, and then there was kind of a space of nobody that was really doing it, and then we got another manager, and I just don't think, sometimes if it's not a manager's passion, it's hard to be, really into, and that's kind of what this has required, is that you have to be really passionate about pediatric patients and doing the best thing for them. And so that was, I think, the turnover, and finally, we got another director, but only in an interim fashion, and she said, hey, I need somebody to, who's passionate about this. And so she went to nursing staff versus just assigning it to the manager, and that's where I got involved. And so we've just had a high turnover at our hospital for, other reasons other than this program.
And I guess my question is, in part, were you given information on how to transition in this role, or were you literally starting from scratch as this role was handed off to you?
I did start from scratch. I wasn't given much from the previous care coordinators.
Wow. Well, impressive work for not having much prior support. Were you able to use the corner of the website for new champions?
Yeah.
Yeah. Okay. Go ahead.
So I went to the national website and read on that, and then ENA has posted the 2009 checklist, and so I started out with the 2009 checklist, and then Rachel Ford informed me that I should be using the pediatric readiness paper that I referred to, and that had a lot more information, but it was very overwhelming. And so we just started with equipment and went from equipment to vital signs and just trying to work through that. I do work with a physician on the group, and she has been very helpful for setting the goals also.
Great. Well, thanks for all of your efforts and great work. I suspect there may be a few other questions for Jessie. Anyone else have questions for her or her team? Okay, thanks so much. And I know that the turnover you all are experiencing is not unique. And previous work, we've seen as much as a 50% turnover per year. So it does become a real challenge. And I know we've spoken at some of our previous learning sessions, the value of building a team as opposed to just having a single individual serving in this role, that it helps to create more redundancy and sustainability and eases the burden when there are transitions in staff or handoffs. So just a great kind of point to help emphasize this work. And well done. Thank you.
You did a really good job. And it might be sufficient to say, Kate, that we have a new version of the checklist. I know you said the guidelines are pretty overwhelming, and they can be. And an updated version of the checklist is coming. And so that will be distributed out here shortly that you all can use to ensure your pediatric readiness too.
Oh, and it is actually newly posted to the EIC website. So for those of you that want to go straight to the EIC website, not under the PRQC, but if you search Pediatric Readiness Toolkit, you'll find a link to the updated guidelines, and I'll work to post that in the chat box for those of you who are interested in accessing the 2020 checklist.
Yeah. I can email it out to the whole group. That might be worthwhile doing too. So I'll email that out after the learning session.
Thanks, Rita.
Yeah. And with that, I'll turn it over to you, Marianne, to talk about your work.
Awesome, thank you. Hey guys, I'm Marianne. I am one of the trainers at one of our training sites for the New England EMS team. Next slide, please. So just an overview of our team. We do have sites across 3 different states up here in New England. And this is just kind of showing where our sites are. Next slide, please. So we always like to talk about a safety story if we can, and I thought this was kind of an interesting story. One of our sites talked about that they made such improvement in obtaining weights in kilograms at their institution that when their scale broke and they had to use an older scale, they didn't realize that it was actually measuring in pounds and had a medication error because they were so used to documenting in kilograms that the patient actually got a 2-fold higher dose of Motrin. This incident obviously helped them get a new scale pretty quickly, but it's an interesting story to kind of demonstrate a win in this quality improvement initiative, if you will, because the work was so effective that the team members became so comfortable with weighing in kilograms. Next slide, please. I won't go through each line on these slides because they are quite dense, but we wanted to highlight some of the successes of our teams. Many of our affiliate sites did different bundles, which was interesting to work through and for us all to be able to learn from one another. But what we found is that sites that have more PEMs seemed to be able to make changes a little bit quicker, which is not necessarily surprising. We did have some great successes. So one of our sites, our hospital, Central Connecticut, had baseline data of 43%, and we're now at 94% with vital signs, which I think is really impressive. Based on some of the work and all of the other excellent work that our tech from that site was able to do, she was actually promoted, which is amazing for her and well-deserved, but I think a credit to how hard she works on everything that she does. We struggled, many of our sites, with staff turnover, as a lot of other sites have done, as you can see. And then next slide, please. And then one of the things that we were able to do with UConn Health was create a partnership between surrounding pediatric transfer. So not only were they able to improve their transfer policies, but able to actually provide feedback to their providers in their own institution from the Children's Hospital about their transfers. And then, so I think some of the challenges that we have found from our team is staff turnover and kind of staff buy-in was one of the things that different sites struggled with differently. Next slide, please. So as we move forward, we are excited that so many of our colleagues are being recognized for the great work that they're doing, both within their institutions as well as regionally and nationally. I think we're quite proud, I'm going to speak for everybody, but we are quite proud with the regional relationships that we've been able to make, which has made our community stronger, I think. And so we are quite proud of those relationships, and we now are tasked with working towards sustainability. I think those relationships
help to foster that and make this transition as we transition away from this formalized program into our everyday work. I think it's going to just make that transition so much smoother because of the relationships we were able to foster. Next slide. And that's it.
Great, thank you so much. Does anyone have any questions, comments?
This is Pat Frost. For your EMS partnerships, were they part of the general EMS system, or were they really the hospital's medical transport dedicated pediatric EMS types?
It's a mixture of both. So we have two children's hospitals in the state of Connecticut where the majority of our affiliate sites are located, and we each do have our own transport team. But from an EMSC standpoint, statewide and regionally, most of our partners are independent EMS units or companies.
Were there any, challenges or feedback that you received from the EMS communities in terms of, working on this project with you?
So all of our affiliates for this project were hospital-based.
Okay.
We didn't work directly with our EMS colleagues.
Okay. Well, and the turnover you described with the hospitals and the challenges that are existing there, it makes it really tough for some of the work that you guys have been doing. So thanks for sharing some of that openly. It does really just bring to the forefront how challenging some of this work is, given the other priorities that exist. And so I think it's really important that, we turn to celebrating successes, which is that despite all of these challenges that many of you have just heard between turnover and, hospitals filing bankruptcy and changes in physician groups or ownership and things of the like, that we've still had a lot of successes that have come out of this collaborative work. So we're grateful for everyone's efforts that they've put into this, because I think the data shows that you really have made an impact for those patients that both you serve at your individual site, but also within your region and more broadly. So Meredith, if you want to go on to the next slide. So this is just an overview of all those who are currently participating in this work. We have 112 that are actively engaged in data entry and reviewing their work. We have a number of others that continue to participate in our calls and are learning, even if they're not actively engaged in some of the data entry work. And that's perfectly fine. We think that there's still a lot to be learned just from others and from the improvements that have been made and best practices that have been shared. Overall, there are about 6,700 patient charts that have been reviewed, and that's, I think, really incredible. It speaks to the dedication and the work that all of you have been doing, and it really allows us for the first time to begin to even see what the state of pediatric emergency care delivery looks like. And this was really an enormous effort by all of you, and we're grateful for your ongoing participation, and we hope that you're beginning to see the significant benefits that have occurred at your site because of this work. So if you'll move on to the next slide. There are a number of best practices that have, of course, been shared throughout the course of the collaborative. You just heard some of them, but we really wanted to put those up here so that folks can recall what has been implemented, what has been done, and that you can really begin to look to others to, gain assistance or share tools, resources, and the like. We just heard about new scales. Of course, not all equipment works properly all the time, so when scales break and the like, but we know that building that infrastructure can be a really important piece. Policy changes, of course, and that's made a huge impact, I think, across all of those first three bundles related to weight and kilos, abnormal vitals, and interfacility transfer. You know, when we think about key drivers and drivers of change, education can play an initial role, but it's not as sustainable as really changing policies, procedures, infrastructure, EMR, and the like. So we're really excited to see the amount of effort that has been used to develop more formal policies within your institutions and the changes that have been made because of that. With respect to interfacility transfer in particular, it's really nice to see policies and criteria being developed to decide what patients do and don't require transfer out of a facility, because this helps to really standardize care and make sure that all children are really getting the same level, as opposed to that variability that might exist between providers and individual decisions. Other key points that we've seen, of course, does relate to education and or knowledge reinforcement. You just heard about badge buddies and or posters for identifying abnormal vitals and really making sure that those criteria are available. You've heard about education that's being provided, and as you just heard on today's call, the monthly education that's being done within the emergency department can be extremely helpful, just to keep the entire team really on track with you know, the needs of children. Other tips and tricks, of course, have come out related to vital sign collection. You also heard that there are a few sites that are working on creating educational videos to be able to share with their teams. Suja Iyer spoke about that on the last learning session, and I know others are also working on similar efforts. And of course, doing some one-to-one feedback. We've also talked about electronic medical record optimization and or EHR integration, and we just heard a little bit about how that might be done in Epic, but it can be done in a number of other different software programs, whether it's Epic or Cerner or WellSoft or others. And we think that the more that providers and or institutions go to these organizations to request optimization of the electronic medical record, the more it will start to push them to really create these safety processes and procedures as part of their normal packages. So we're excited about the work that's being done there. Lots of really exciting work that's happening with respect to disaster preparedness and you know, making sure that child life is involved in developing better tracking forms for intake and admission and discharge. And then really the work that's been done at the team level of really communicating regularly between the trainers and the champions, and having team meetings, developing, you know, better engagement across the board. And I think we've heard over and over again how valuable those meetings are, of just being able to collaborate and not have to reinvent the wheel every time. So we'll move on to the next slide. Great. And I will turn it back to you. Oh, sorry, let me just talk about sustainability planning first. Sujit Iyer gave a really nice talk at the last learning session about sustainability planning. And as we move into the last month of this collaborative, we really want to challenge you all to think about how you're going to be able to sustain some of this work within your individual site. And we know that specifics regarding the data entry system and future planning for that have not been fully described. And as many of you may or may not be aware, the EIC is up for competitive renewal. And so part of the future of this particular collaborative is dependent upon that, which is why some of this is still being worked out in full. But there are a few key points that we hope everybody on this call will take back to their institution. which is related to the various levels of engagement that you need for true sustainability. Part of that is making sure that you're, of course, engaging the bedside staff. You've heard about the many ways to do that, but really being able to speak back to the staff about what improvements are needed, why they're needed, being able to provide examples, being able to identify those real champions, those who are really passionate about this work, maybe even those who have had an adverse event or a bad outcome that they want to share and use to help drive home the importance of these efforts. At the ED leadership side, you all have heard a lot about turnover, and this is where having really strong leadership engagement becomes critical. We know that staff will turn over every so often, and really making sure that the ED leadership is aware of how important this is, because it really becomes a risk management or patient safety issue. Of how do we ensure that we're meeting the needs of these children on a regular basis? How can we maximize efficiency in terms of pushing resources and our needs towards the pediatric population, really integrating those needs within even some of the adult priorities to make sure that there's greater efficiency of that. And then, of course, at the C-suite level, and I think we've talked about this a lot as well, is that many of you that have been involved in this work are doing such incredible amount of work and effort to really ensure the needs of children are being met, but we're not necessarily great about tooting our own horn or going back to the C-suite and telling them about all the great work we're doing. The problem is if we don't go back to our leadership and tell them about all this great work, they're not going to understand the value that you're bringing to the institution or to the community as a whole. So we really encourage you to think about inviting your C-suite leadership to the final learning sessions that are coming up in April, to engaging them in your team meetings, and to being able to share the progress and the improvements that have been made, both through your actual dashboards, how you compare to other sites, the efforts that you've initiated, the education that you've developed, the policies that you've changed, so that they really hear how important this effort is as you move forward. The other thing that I would add is do not be afraid to share some of the evidence base that exists relative to pediatric readiness. I know we've mentioned it on previous calls, but there was a recent publication by Stephanie Ames and colleagues that showed that those emergency departments with higher pediatric readiness scores have a 3- to 5-fold decrease in mortality for critically ill children that present to their ED. And when we see differences in mortality, especially in the pediatric population where mortality is already low, we know that this has an immense impact on the populations that we serve. And you should be willing to share some of that evidence base with your leadership. So one of the cycles that Sujit Iyer shared on his discussion was what you see here, which is really defining what some of the issues are in your institution, developing those solutions, implementing them, and then being able to share those successes or barriers. And all of this work really needs to be shared across all 3 of those levels that we just talked about, from bedside staff to ED leadership to the C-suite, to really create ongoing sustainability. If you'll go to the next slide. This just provides you the link where you can go to hear Sujit's talk that he gave at the last learning session. If you have any questions about how you're really going to implement true sustainability in your institution, we really encourage you to go back and listen to that. Sujit's done really incredible work, and we hope that some of you all will engage in those efforts too. So now I'll turn it back to you, Meredith, to talk about some of the final tasks.
Great, thanks, Kate. So we have about 3 tasks remaining for you all until the close of the collaborative. And the first is going to be the final team presentations. We're going to have 2 of these final team presentation learning sessions, one on April 7th and one on April 21st. And you can see the teams listed here. I did this purely in alphabetical order, so if you have a conflict or an issue and we need to trade these around, please email me and we can figure out dates. Because as Kate mentioned, we really encourage you to invite your hospital leadership so you can showcase your work, show your successes, your best practices, really what the impact of the collaborative has been on your institution, and how you're planning to sustain these efforts. Recommending again, once again, to watch Dr. Ayer's talk, and then we really want to hear just the team in general, how, and from specific affiliate sites, how the impact of this collaborative has been on your institution. So that's the first task, April 7th and April 21st. You should have all received calendar holds. If you haven't, please email me and I will forward them to you. Step 2 is to complete the NPRP assessment. Now, you may have remembered, some of you that were with us for the beginning of the collaborative, you were required to complete this at the beginning of the collaborative. And so this is the 2013 NPRP assessment. It's based on the previous guidelines. Because the new assessment, which I'll talk about in a second, will not come out until June. And so this is going to be a PRQC specific website. It's just for the collaborative. It's going to be open April 1st through April 30th. It is the exact same assessment that you completed at the beginning of the collaborative. So this will be open. You will get a link from me where you can go in and complete the NPRP assessment. If you remember, our overall aim, SMART aim for the collaborative is to improve collectively our pediatric readiness score by 10 points. And so this is our primary aim of the collaborative. Is we really need everyone to complete the assessment one more time so we can get this measurement. If you will not be able to do the assessment within the April 1st to 30th window, please let me know, and you can complete it by paper and email it to me. And here's just a preview of the paper version. We actually encourage everyone to download the paper version, print it out, complete it, and then go into the portal and enter all your answers. It makes it a little bit more easier to complete. Any questions on the NPRP assessment and what that's going to look like?
Just really quickly, Meredith. So the one difference about this assessment is because the current 2013 portal, initial portal, is now closed, and that's in preparation for a future reassessment later in 2020. So the only real difference with this particular assessment is that you will not receive the full gap report that was given at the end of the other collaboratives, where it would direct you to all of the various resources. You'll still receive a readiness score. You can still identify where your gaps are, but it won't provide you with a more formal gap report. The other piece that I just wanted to add about the importance of this is that if you feel like this collaborative was useful, this work was useful, if you felt like this really added to your ability to meet the needs of children, we really need you to complete the assessment, because it's only through our ability to demonstrate improvements that we're able to carry on with this kind of work. And so we are really hopeful that all of you will just go back through and complete it. It should be very quick and easy for you, relatively painless, because you've done this so many times before. We've been talking about pediatric readiness for the last 2 years. But if you will please just take 10 minutes to recomplete that assessment, it would be extremely helpful in informing future collaborative efforts and us being able to carry on with these kinds of initiatives.
Kate, it's Diana. I'm going to chime in briefly. I know Meredith mentioned or suggested that you print out the assessment and then come back and enter it into the data system there. The reason for that being the assessment, Kate's correct, it's very easy to do. You've seen it before, but it is a tad long. So you may have to do the assessment in phases. That by doing the paper form, you can go and you can save your documentation and go back into the system then and enter it all at one time. So, but it should be fairly easy this time since you have done it once before. Thanks.
I'll talk to this then.
Okay, any other questions about the assessment or the previous slide number 1, the team presentations in April?
Yes, hi, real quick. Where can I find this assessment tool? Just briefly, I was handed this entire packet and all of this on Sunday. So I've never filled out this assessment. So where can I find the online version? And I think my manager is getting me the written version.
We will be sending it out to you all because it's no longer on the Peds Ready portal. So we'll send it to all of you via email. Just make sure that Meredith has your contact information if you're new to this collaborative work.
Awesome. Thank you so much.
Yeah, you can stick it in. And come April 1st, it'll also be posted to the members only website too, so you can download it from there. But yeah, just stick your email in the chat box, make sure I have it so that I can make sure it gets to you.
Okay, I'll probably send you an email. I had to call in because
that's fine.
would
Yeah.
not work with this for some reason. So yeah, I will definitely reach out to you via email for sure.
Okay, great.
Any
other questions? Okay. So the last thing we are asking you guys to do, and this will be sent out in April as well, is complete an exit survey. Really, it's asking every site, affiliate sites, and training sites that participated, so training sites that entered data, to complete this exit survey. We're going to put another survey together for the trainers, but this one is specifically asking for feedback on what did the structure of your internal teams look like, what is your opinion of the overall design of the collaborative, the data entry system. We're also going to give you the opportunity to sign up to be part of a focus group for future collaborative designs. And since you all have gone through this once and really worked hard, your experience is invaluable to us. And so as we think about designing future collaboratives, if any of you would like to be part of a focus group where we can run design ideas by you, you'll have an opportunity there to sign up to be part of the focus group. This is also where you're going to put who you'd like us to address the certificate of appreciation to. So this is going to be signed by HRSA, and it's meant to be framed and hung in your ED, and it's going to be in recognition of your participation, a certificate of appreciation for participating in this collaborative and really working to improve the care of children. And so at the very end of the survey, you can put up to 3 recipients, either your hospital leadership or yourselves or whoever you would like this sent to, as well as please, it'll ask you to list all the names that you would like printed on the certificate. So that is the third and final requirement. You must do the team presentations, the NPRP assessment, and the exit survey before we will send the certificate of appreciation. Besides that, of course, remaining ask is to continue entering data. We still have 2 months, so still some time to get some PDSA cycles done and data entered into the data entry system. I think.
And just really fast, Meredith. So with respect to the certificate of appreciation, on the exit survey is where we ask to whom you would like that certificate sent to make sure that we have the appropriate address and the like. And that's why it's so important that you also complete that exit survey so that we can send that certificate of appreciation to you all. And this is really for your institution, for your hospital, and something, again, to take back to your C-suite and ED leadership to show them all the amazing work that you've done. This is really an accolade for your effort. So I just want to make that clear. Thanks.
And I think this last slide is just to make you, last few slides are just to make you aware of some of the other activities going on in the MSC space as this collaborative comes to a close. Some other groups you can become a part of to kind of as part of your sustainability planning. One here is the NPRP Community of Practice. This is actually not led by us, but by AAP, but a great community of practice. All the information is housed on our website. We're partnered with them, and the link is here. I can also stick it in the chat box. They've had a few webinars. They have more upcoming. Kate has spoken to this group as well, and you get access to all sorts of resources and a bunch of more hospitals and people working toward pediatric readiness. So a great opportunity, something to become a part of. And then, Kate, I don't know if you want to talk a little bit more about defining the PEC role.
Sure. So as many of you may be very aware, is that over the last decade or more that we've been really working towards improving pediatric readiness as a collaborative national effort with our partners at AAP, ASAP, ENA, and then of course HRSA EMSD. Is one of the real big gaps as well. We understand that having a PEC improves readiness, and we know generally what roles and responsibilities a PEC might play. We really don't know all that much about who is serving in this role, what's their background, what exactly are they doing, are they being supported? And one of the challenges with not knowing about what these individuals are doing is that it's really difficult to more formalize the role. So in other words, how do we actually bring this role into part of an organizational chart? How do we formalize it in a more long-term capacity? And one of the ways of beginning to do that is by beginning to understand who is actually serving in this role. So those of us at the EIC and at NEDARC are working on an effort to better understand who you are, who these individuals are, not just those of you participating in the Pizza Ready Quality Collaborative, but also additional PECs. And we realize that we've had a lot of asks during this last learning session about what's coming up. But this is one of the other pieces, is that if you want to help us to better formalize this role, learn how to formalize this role, then we'd like to try to hear from you. So we will be in the near future sending out another brief survey, and we hope that you'll consider providing us with a little bit of feedback about how your role has been supported, if it's been supported, and the kind of work that you've actually been doing. So that's that. You want to go to the next slide, Meredith? We also recognize that it's really important to be able to share and spread this news to continue to expand the impact of this work. And there are a number of individuals who've been participating in this collaborative over the last 2 years who have volunteered to be part of groups to try to spread the word through manuscripts and the like. And if any of you are on the call and are really interested in being part of this, we welcome you to send us an email and let us know. We're happy to include as many as possible in future manuscript efforts. These are a few of the folks that have volunteered. Many of them are trainers who've been working on this effort. But if you're interested, please shoot us an email so we know, and we're going to begin to work on pulling these teams together to help get the word out about the improvements that you guys have made. And again, this helps us to continue future efforts to support these collaboratives and Pete's Ready work. She'll go to the next slide. So just really fast, I wanted to turn the mic over to Pat Frost for just a second, because she is one of the executive members, vice chair of the executive committee for the National Pediatric Disaster Coalition, and they have some work underway that might be helpful to join. So Pat, do you just want to mention that briefly?
Yeah, given the COVID-19 event, the National Pediatric Disaster Listserv and our colleagues and champions are really focused on sharing information around pediatrics, even though it's a small amount of information, but there's some very important information coming out in terms of schools and childcare and workforce, even though it looks early on that the morbidity and mortality in children is a lower risk than in adults. We would like to invite you to join the listserv. I'm going to put the information at NPD Coalition to help spread the word. We are also working with both Centers for Pediatric Disaster Excellence on the West Coast and also East Coast, and both of those centers have expressed the wish to assist and be a resource in communities. So if you have an ask, if you need something, if you don't know where to go, or you need some information specific to PEDS or an example, please reach out to us. We do realize that the hospital preparedness program is working on your pediatric annexes, and both centers are very interested in doing that and helping you guys with that.
Great, thanks, Pat, for sharing that. The National Pediatric Disaster Coalition, I know we've spoken about their organization at a number of previous learning sessions and in-person sessions. So please do reach out if you're working on working with your healthcare coalition to build your pediatric surge annex. They have lots of wonderful information and resources, and feel free to join the listserv. So perfect timing. I'll turn it back to you, Meredith.
So I just jumped ahead a couple slides because this is right on topic. And I wanted to just follow up with Pat's comments that there was a webinar last week put on by Ask for Tracy, which discussed the pediatric surge annex. The PowerPoint slides and a recording of that webinar are now available, both here in the links. You will be asked to enter your name and email address prior to accessing the recording, but it was a fantastic presentation, lots of great information about developing a pediatric annex, and so I would recommend you all take a look at that if you're beginning to work on disaster. Let me jump back here a few slides, just a few wrap-up items. I guess let me pause here for a second. Any questions for Pat or anything surrounding COVID-19 or disaster preparedness? Okay. So just a few remaining items. We just kind of wanted to remind everyone about the all teach all learn culture. We're all working together, and we really want to encourage you to share what's working. Consider sharing your resources. You have really great badge buddies. You can email them to me. I can post them. Any other staff educational tools or PowerPoint presentations that you use for staff education, anything that you think might be useful to someone who is new to pediatric readiness that could really use, like, gee, I wish I would have had this developed when I came and started working on this stuff. And if you send it to me, I will make it available to everyone in the collaborative. I can de-identify it if you don't want your institution associated with it. For example, if you don't want your policies to have your name on it, but would love some template policies or example policies, we can de-identify them. So send those to me, and we can really share them with everyone in the collaborative working on this. I wanted to draw your attention to a couple new EIC resources. This has been a big project and will continue to be a big project within the EMSC space. And it's modeled, if any of you are familiar, after Trek Canada. And so this will live on the EIC website. We're going to have resources and focus on all different priority conditions. Right now, our first condition was seizure management, but there will be resources for providers, for pre-hospital providers, for families, for policymakers, and we'll have things such as decision pathways or order sets. The first thing we have up right now is a really great 5-part series. It's 4 podcasts and 1 video for the pre-hospital provider on managing seizures. And it was put on by Julie Magana, who does a great podcast called Pulse. And she worked with a few of our other, one of our experts here at Texas Children's Hospital, Ms. Shaw, to talk about how you really treat seizures in the field, how do you recognize them, and there's a great video, about 10 minutes long, on intranasal administration. So check those out. There's more to come. Like I said, this is an ongoing work. We're going to expand this so that there will be resources applicable to everyone, including hospital-based providers and different conditions. We're going to build first again with seizures. We'll soon incorporate the febrile infant and some other conditions. So keep checking back. Great resources coming to the IC website. Mentioned the Ask for Tracy Pediatric Surge webinar, and I think that's it. So any questions, here is the link and the QR code for the CNE credit. And I'll open it up, questions, comments.
This is Pat Frost again. I just wanted to mention that even if you're not, specifically working on disaster, one of the most important things that the NPDC does is help connect novice to experts. So we really need as many people to kind of, spread the word. And also, your community better than anyone. And so the needs, and when issues and questions come up, if you can refer them, or if you join our listserv and we have a resource and you know someone in your community that could really get some help with this. We are multidisciplinary, so we need your voice to spread the word. Very much like, all the pediatric readiness activities do. So, and we invite everybody to get connected with us so we can support you and your community.
Meredith, do you mind just going back to the list of teams that are presenting in April so that folks can see this again? Just to make sure that you know when your team is scheduled to present. And again, we really encourage you all to reach out to both your ED leadership and C-suite to see if they're available. If for some reason you desperately need to switch because of the availability of your team or your leadership, please let us know within the next week or so that we can make that switch happen. We're really counting on everybody to be able to give their final presentations and really be able to celebrate all of the successes, and we want to make sure that it's going to be most impactful for you. So please just again take a quick look at where you are. The 2 dates are April 7th and April 21st, and please go ahead and reach out to your leadership sooner than later to see if they're available to attend as well. So thanks everyone for joining the call today. Are there any last questions, comments, concerns? Okay, well, we are giving you all back about 13 minutes of your day. Thanks so much for your time and for the wonderful presentations, for the great work, for the best practices shared, and good luck over this next month. And we look really forward to your final team presentations and hearing about how you're going to maintain or sustain these efforts. So many thanks to all of you. Have a wonderful rest of your month, and we'll see you in April.